Assalamu alaikum. My name is Abdul Rafe and my roll number is BP165004. I belong to 4th Prof morning program and my group number is 35. Today I am going to give a presentation on renal failure, drug dosing in renal failure, anti-pseudomonal penicillins and the case related to it. So let's start with renal failure. As the term indicates, it is a combination of two words, renal and failure. Renal is associated with kidneys, while failures means to be unable to do a specific task. So renal failure means that kidneys are unable to do their assigned task in a proper way. Means that kidneys are working in improper way or kidneys are unable to do their normal routine activity. In renal failure, kidneys are unable to filter the blood which they are filtering in their normal routine activity. This might be due to different problems. These problems can be diabetes, high blood pressure, or glomerulonephritis or polycystic kidney disease, or this might be due to the blockage in the kidney by kidney stone or scar tissue. This kidney failure will lead to appearance of different symptoms, but these symptoms will be different according to the condition. The condition might be of acute renal failure or chronic renal failure. In acute renal failure, we will see that there are different conditions, and in chronic renal failure, we will see that are different condition. But before going to that, we will discuss chronic kidney disease, in which kidney is affected at different pace by different stimulus. At right hand side, you can see that the kidney is functioning normally, while due to any factor it starts to increase the risk of its damage, and when the kidney starts to damage, its function is reduced, and when the function is reduced, kidney fails, means it stops to function in a normal routine way. So this is a flowchart plan that how the kidney is damaged. So going back to our main topic, which is renal failure, and discussing acute renal failure. In acute renal failure, it occurs when the kidney suddenly stop filtering waste products from the blood. The signs are edema of hand, feet and face, means the hand, feet and face starts to swell. The other signs are internal bleeding, confusion, seizures, coma, abnormal blood and urine tests, and high blood pressure. While in chronic renal failure, there are different symptoms which we will see after discussing chronic renal failure. Chronic renal failure builds slowly with very few symptoms in its early stage, means we can't pick it up in its early stage, means it is more worse in condition and it will affect the body more, means it is lethargic for the body and it may be fatal. A patient with chronic renal failure may not have any symptoms until kidney function declines to 20% or less, means the 80% of the functioning of kidney will already be lost. At that stage, these signs may appear: abnormal blood and urine test, high blood pressure, weight loss without any reason. The patient might be losing its weight, low red blood cell count, which is anemia, nausea, vomiting, metal taste in mouth, loss of appetite, shortness of breath, chest pains, numbness, and tingling might be the other symptoms which will occur in chronic renal failure. Now discussing the drug dosing in renal failure. By discussing that, we are discussing anti-pseudomonal penicillins directly. So, drug dosing in renal failure, uh, renal disease alter the effect of many drugs, sometimes by decreasing their effects, but more often increasing their effect, and thus potential toxicity. By increasing their effect, they increase the toxicity level. Many of these changes are predictable and can be changed by changing drug doses. Renal disease interact with drugs in three main ways. First is patient susceptibility, means the patient may be vulnerable to a given drug effect or drug dose. Second is pharmacodynamic change, means a drug effect may be exaggerated or attenuated in patients with renal disease. Third is pharmacokinetic change, means some drugs have higher steady state concentration when given at usual doses to patients with renal disease. This can be summarized in a one-liner that we can treat the patient which are renally compromised or have renal disease or renal failure, or by drug dose should be reduced proportionally to the predicted reduction in drug clearance. Increased drug clearance results in lower drug concentration, while decreased drug clearance results in higher drug concentration and hence greater drug effect. To avoid harm when drug clearance is significantly decreased, the dose of renally cleared drugs should usually be reduced in patients with renal disease. Now, going to a case study and discussing it. MH is a patient who is 44-year-old and 70 kg woman with acute non-lymphocytic leukemia. She is admitted to the oncology ward for placement of a Hickman catheter for her chemotherapy. 7 days following treatment with cytarabine, Ara-C, and daunorubicin, her temperature spiked to 39.4 degrees Celsius. Other physical findings are consistent with sepsis, included a blood pressure of 109 by 70 mm of Hg. Pulse rate of M and H is 102 beats per minute. Her respiratory rate is 27 breaths per minute. MH is neutropenic with a WBC count of 1400 millimeter cube. 3% polymorphonuclear leukocytes, 70% lymphocytes, and 22% monocytes are included in her WBC count. Her platelet count is 16,000 millimeter per cube. MH is also renal dysfunction as reflected by an SRCR and BUN, which are 2.6 and 38 milligram per deciliter respectively. Empiric therapy for sepsis is started with tobramycin, piperacillin, and tazobactam, and vancomycin. How should piperacillin and tazobactam be dosed in MH? So, discussing it in a brief and detailed way. First, we will prepare soap notes. Soap notes are the basic formula to discuss or to solve a case, or it means soap. S stands for subjective, O stands for objective, P stands for plan, and N, sorry, uh, A stands for assessment. Let's start with subjective. In subjective, we made old cards. Old cards means onset, location, duration, characterization, elevating factors, radiation, temporal effect, and severity of the disease. So, In our given data, we concluded that the gender of the patient is female, her age is 44-year-old, while her weight is 70 kg. She has a complaint of acute non-lymphatic leukemia and renal dysfunction, while her medication history is 7 days following treatment with cytarabine, Araci, and daunorubicin. Her current medications are empiric therapy of sepsis, started with tobramycin, piperacillin, and tazobactam along with vancomycin. So, objective of this case will be that vital signs which we have noted are temperature 39.5 or 4 Celsius, blood pressure of 109 by 70 millimeter of Hg, her pulse rate is 102 beat per minute, while her respiratory rate is 27 breaths per minute. Her lab reports shows that WBC count is 1400 per millimeter cube, in which 3% polymorphonuclear leukocytes, 70% lymphocytes, and 22% monocytes are included. Her platelet count is 16,000 per millimeter cube. Her SRCR and burn ratio are 2.6 milligram per deciliter and 38 milligram per deciliter respectively. Now, assessing what we have given in our case, according to the lab reports, MH is neutropenic and also has renal dysfunction. Her temperature is also elevated after treatment with cytarabine and daunorubicin, which are chemotherapeutic agents. She is also consistent with sepsis. Now, planning what we should do. Piperacillin is partially cleared by biliary excretion, a route of elimination that is increased in patients with renal failure. Therefore, aggressive dosage reduction in MH are unnecessary. An appropriate dose of piperacillin tazobactam for MH would be 3.375 gram every 8 hours. Conclusion: piperacillin is an anti-pseudomonal penicillin that is often used with an aminoglycoside to treat serious infection caused by gram-negative organisms. Piperacillin is commonly given as combination with tazobactam, a beta-lactamase inhibitor. In patients with normal renal function, piperacillin is primarily excreted unchanged by the kidney with a clearance of 2.6 milliliter per minute per kg and half-life of approximately 1 hour. Doses of piperacillin tazobactam can be as high as 4.5 gram every 6 hours for the treatment of serious pseudomonal species infections. In patients with ESRD, mean piperacillin clearance and half-life values are 0.7 ml per minute per kg and 3.3 hours respectively. Although these parameters are significantly different, they are less than those expected for a drug primarily cleared by the kidneys, suggesting that some other compensatory mechanism for elimination must be present. Thank you.